Okay. So good. I think good afternoon, good morning for someone. Good afternoon, everybody. Dr. Sunita, are you ready to open the CPC for today?
Yes, I think people are still joining, but it's exactly like maybe a couple more minutes. Do you think go or we start first?
Yeah, maybe we start with the introduce the Pringo Dingo first.
Sure.
Waiting. Do you
Okay.
want to introduce him or
Yeah, I can do that. All right. It's actually Dr. Pringo Digdo who is actually presenting or his unit.
This his unit.
It is his unit. Okay, give me 2 minutes and I will get ourselves organized a bit better. Okay, so I'll come down closer to the camera. Well, good afternoon, everybody, and welcome to our OSEA CPC session. Today, we are very privileged to have Dr. Pringo Digdo, who is actually the president of the Indonesian Society of Nephrology, PENEPHRI, and his unit from the Cipto Mangunkusumo Hospital, Universitas Indonesia in Jakarta, will be presenting us a case of a 19-year-old female who presented with proteinuria and hematuria. So over to you, to the team at the Cipto Mangunkusumo Hospital.
Thank you, Dr. Sunita, for your kind introduction. Hello, everyone. Prof. Gov and dear colleague, I'm with my team in Jakarta, and Dr. Orisa will present a case.
It's a big team. Just a quick reminder, please keep your microphone mute unless you are speaking. If you have any questions, please feel free to drop them in the chat box. Okay, Dr. Pringo Dingo and Dr. Orisa, please.
Thank you, Dr. Pringo, Professor Gov, Dr. Sunita, for the introduction. Let me share my screen. Okay, can you see my slide here?
Yeah, of course.
Okay. Good afternoon, Professor, Doctor, and all college. So thank you very much for the opportunity to present one case. Here, an example of one case in our institution here. So before we begin, let me remind that Indonesia is a hosting country for the upcoming 8th Congress of Asian Pacific Society of Dialysis Access, or APSDA, in conjunction with annual meeting of PENEPHRI, or Indonesian Society of Nephrology, that will be held in Bali in 10 to 12 October 2024. So for the professor, doctors, and also all the college, if you want to come to Bali, to Indonesia, you can register here. You can scan QR code in here, so we can join together in Bali. Okay, so let me present the case. So the patient is Miss NPA. She's a female, 19 years old. She's single, and she is a college student. So this patient with chief complaint is foamy urine and swelling in the legs. So in 2014, at the age of 9 years old, she had experienced rash in the face, and the rash was spread in the arm and both legs. And she also had pain in the joints and also hair loss. She also had a recurrent fever in 9 years old. So with this data, what step we do next? Maybe Dr. Pringo, can you lead the session, maybe?
Yeah, maybe any participant want to suggest what should we do next?
Pringo, I think your sound is echo. have to close one of your channel. Yeah, horizon.
Anyone to want to any next step?
Okay, we have one volunteer from Hospital Kuala Lumpur.
Hi, Dr. Imran here. In regard to what step I do need to come in, I assume that we have a good enough history from her. With this kind of history, I do suspected of autoimmune diseases. So I would like to send for the full blood counts, all the routine renal function tests, liver function tests, and also look for immune screening like the ANA, double-strand DNA, C3, C4, and ANCA, and the rest also.
Yeah. Riza can.
Sorry, can you repeat that?
Thank you, Dr. Pringgle. So I can continue. That in the 2014 that the result of AA is positive and also high anti-dsDNA. So and that time the patient was diagnosed as lupus, and she admitted to the pediatrics and given methylprednisolone, hydroxychloroquine, and also mycophenolic acid. So in 2014 under 2022, she was routinely admitted to the pediatric outpatient patients, but few times she did not comply to medication. So the steroid the few times were higher dose and the step down for a moment. Urinalysis not found any proteinuria or hematuria at that time, and also rash and joint pain were improved. But in 2022, she had foam urine. The result of UPCR is 200 milligram per grams, with ncDSDNA is 746. That's high. The normal in our institution is under 100, and the C3 is low, C4 low, but still normal kidney function with the urea 10 and creatinine 0.5 with the eGFR 140. The treatment was MPA 540 and 360 milligrams with methylprednisolone 1 × 8 milligrams and also hydroxychloroquine 200 milligrams. In November 2023, she suddenly had progressive paralysis and also numbness from pelvis to both legs. She had also fever, rash in the face. She had urinary retention and better when use of urinary catheter. She also had foamy urine, more prominent, and also leg swelling. She planned to do kidney biopsy, but at that time, she cannot retain prone position because of the paralysis from the pelvis to both legs. She had also history of gingival infection and fever 4 months before. So after the diagnosis, she diagnosed as SLE-related myelitis and lupus nephritis. The result from the proteinuria is 1,347 milligram per 24 hour, where the anti-dsDNA is still high. Its urine erythrocyte is more than 50 and albumin 1 positive, and low C3, C4, low albumin, but still normal kidney function. And at the time, she had given full dose methylprednisolone 500 milligrams for 3 days, but there are no improvement of the symptoms. And continue with the induction protocol of cyclophosphamide 750 milligram per BSA per month for 6 cycles. And present, she routinely underwent physiotherapy. The numbness improving. She can wheelchair right now, can move both legs minimally, and can stand about 10 seconds with help. Urination still with urinary catheter. Foamy urine still present, but no swelling legs and also no rash anymore. No comorbidity, no hypertension, diabetes. No history of stroke, tuberculosis, asthma, allergic. In history, she said that the grandmother sister died aged 10 years with unknown cause of death and suspected maybe autoimmune may be present. She is still a college student. She is the fourth children from 5 child. No history of alcohol, smoking, or intravenous drug use. For the medication history, she had methylprednisolone 4 milligrams, hydroxychloroquine 200 milligrams for 7 years, calcium carbonate 3 times 500 milligrams, vitamin D3 1 unit, lisinopril 10 milligrams, cotrimoxazole 960 milligrams, and cyclophosphamide 1000 milligrams per month from November 2023 until May 2024. And the last dose of the myfortic or MPA is 540 and 360 milligrams before the induction of cyclophosphamide. So the examination, the blood pressure is 108 and over 65 with the normal heart rate and also respiratory rate. From the physical examination, that no alopecia, no jaundice, no pale, and no enlargement of lymph. There are striae in the abdomen and also in the both legs. There are striae because of the long standing of steroids. The motoric is the 5 in the upper extremity and also 2 and 3 in the lower extremity. X-ray is normal. This is the kidney ultrasound. That right kidney is 10.61 centimeter with normal echo density. Kidney 9.98 centimeter with normal echo density. So there's normal kidney from the ultrasound. This is the MRI in thoracolumbar in November. This is suggestive transverse myelitis with syringomelia in medulla spinalis to conus medullaris. No mass or contrast enhanced lesion in the medulla spinalis. This is the lumbar puncture. There's no infection here, so it's suggestive inflammation. The echo is the good LV and LV function. This is activity trend. So from the cyclophosphamide per cycle, there are increasing of anti-DSDNA and also low C2C4. And after 6 cycles of cyclophosphamide, there are improvement of the anti-DSDNA is lowered to 275 and also increasing of C3C4 in June 24 after 6 cycle of cyclophosphamide. However, but proteinuria from the first cycle of cyclophosphamide, there are 1,347 milligrams proteinuria, lowers to 200, but it increasing again to more than 1,900. Then after cyclophosphamide, the trend is not really lower, but it keeps increasing. In August, there are 1,994 milligrams proteinuria for 24 hours. This is the other laboratory result. The FBC is hemoglobin is normal, thrombocyte platelets is normal, albumin is normal, urinalysis thrombocyte 4 to 5, albumin 1 positive, no CAS, glucose is normal, electrolyte normal, and the kidney function also normal. For the antiphospholipid syndrome, we found the lupus anticoagulant positive weak, but negative the anticardiolipin or beta-2 glycoprotein. From video aerodynamic, there are the truth or underactivity, so patient is still on urinary catheter. This is the kidney biopsy. We found 17 glomeruli in light microscopy and 4 glomeruli in IF, but we didn't have the electron microscope.
Jangan dibacain dulu ya, biar dilihatin aja dok. Nanti biar komen dari mereka ada nggak?
Okay, so this is the result of the biopsy. Maybe any comments from the floor?
Dilihatin lagi. Klik terus sampai pelan-pelan. Biar baca dulu. Terus lempar dulu dari peserta yang mau baca ini. Yeah. Anyone want to comment the slide?
Maybe we should start assess the clinical and laboratory first,
Right.
and after that, and discuss about the pathology. So do you have only one biopsy, or you have many, or repeat biopsy, or not?
Only
Only
one
one.
biopsy.
Only one. Okay. Okay. So maybe we gonna start with the discussion about the clinical and laboratory. So anyone want to volunteer the problem of the case after 9 years of SLE and treatment for continuously, and present with the proteinuria go up? And anyone want to volunteer? Maybe if no one gonna be Chulalongkorn, you anyone want to assess?
Good afternoon, everyone. I'm Dr. J from Chulalongkorn Hospital. In this case, the patient has a history of SLE, and she have worsening proteinuria after complete treatment with cyclophosphamide. So and normal creatinine, and so I think from the laboratory result, creatinine is normal. So sorry, during the higher the proteinuria, what about the blood pressure?
The blood pressure is normal.
Oh, okay. Thank you. So from the clinical information, so I think the differential diagnosis, first of all, I think it may be the relapse lupus nephritis is number one, and second differential diagnosis may be the complication. I'm not sure from TMA, or sorry, I'm not sure. Maybe the TMA or the infection, or from the higher immunosuppressive effect. Thank you.
So you need to discuss about why the patient treat with the standard doses of NIH cyclophosphamide regimen, and the patient still have persistent proteinuria. So, and if you think that the lupus relapse, so you're gonna change or swap the regimen, or what else do you think? If you differentiate TMA, what you should looking for?
I think in this case, if the cyclophosphamide good response in the at the initial, if this presentation is relapse lupus nephritis, I may choose the cyclophosphamide again for the induction. And if for the TMA, I will see the UA for the red blood cell, and see the platelets from the CBC, and the blood pressure may still high.
I think he only mentions her urine, and she has albumin 1+, and blood 4 to 5 cell per, this one, right?
Okay, so I think it's maybe less likely the TMA.
Who else want to volunteer and discuss about with extra-renal like a transverse myelitis?
Hello. So good
Hello.
afternoon. Yeah,
Hello.
you can go first.
Um, Hello, may I make a
Ya, Dr. Dina, silakan.
okay,
Please.
yeah. Thank you, Doc. First of all, so we are agreed this is an autoimmune disease. This is a systemic autoimmune disease.
Can you
So
introduce yourself first before you start a discussion?
oh yeah, sorry. Good afternoon, everyone. My name is Dr. Dina Nilasari. I am a nephrologist from Indonesia and working now at Siloam Hospitals.
Oh, welcome. Thank you so much.
Okay. So we are all agreed that this is a systemic autoimmune disease presenting first time as a child, 9 years old, and then without a renal involvement at the time, and then gradually now 19 years old, and there is a renal involvement. What I would like to confirm is the proteinuria at the first place. It's 200. Was it when she was a child, or when she's presenting the first time in the nephrology clinic? And then what I can see is the proteinuria gradually increasing. And when is the timing of the biopsy? Whether it is before the cyclophosphamide administration or after that? Can you just confirm about that?
Yes, so the proteinuria, when they are, so the
So
result
can you back to the first one when it says that it has 200 milligrams proteinuria? Yeah, UPCR. Okay, that's UPCR in 2022 with very low C3 and C4. And how's the clinical manifestations, whether the patient's nephrotic syndromes or yeah, maybe nephrotic syndrome or just nephrotic range proteinuria?
No. This is the result when the patient had sent to the clinic when more than 18 years old, because before the patient were admitted to the pediatric, and the evaluation of the data that there are no proteinuria or hematuria, and when the patient had been sent to the nephrology clinic, we evaluate again and we found that the UPCR 202, but because the result is
Not confirmed.
500, so we continue the treatment.
Okay, and how's the clinical presentation at the time, whether the patient has nephrotic syndrome or more nephrotic? There's no nephrotic syndrome.
Yeah, there's no nephrotic syndrome.
Okay, and the blood pressure is normal.
Yes.
And creatinine normal. Okay.
Yes.
Yeah, and when so the cyclophosphamide administered after the results of the biopsy, or when do you start the
So
cyclophosphamide?
the cyclophosphamide was started after the patient had a progressive paralysis and numbness, and when we were sent to the neurology do the MRI, and the result is the transverse myelitis related with SLE. And after and that time also she had urine and also leg swelling, and we check again the 24-hour proteinuria is 130,047. So this time we do the cyclophosphamide protocol. At that time we did not do kidney biopsy because the patient cannot retain prone position.
Right.
So okay.
Right. So the reason for the indication for the cyclophosphamide is non-renal indication in this matter, or because of the
we should shorten it because I think we should discuss about the breakthrough of proteinuria while on regimen of cyclophosphamide.
Yeah, but we should see when the how many cyclophosphamide cycles and when.
From the flow chart is 6 times, so maybe 6 course of cyclophosphamide. And Orisa, do you have a cumulative doses of the cyclophosphamide?
Yeah.
Before biopsy?
6 grams cumulatively.
6 grams.
Yes.
Okay.
Yeah, because in this case, the patient, we already do the cyclophosphamide for 6 cycles, but the proteinuria is not growing but increasing in the last checkout.
So
Dr. Orisa, what about the dsDNA or serological activity, disease activity for this patient after this cyclophosphamide, after 6 cycle?
Yeah, anti-dsDNA is reducing to 275, and also C3C4 is increasing.
Right. So do we think about like interstitial nephritis that causing by other non-lupus cause? Because I agree that this is not like, it is less like the TMA because there's no rising in blood pressure, no hypertension. So can we see what's other cause of the proteinuria in these patients either? And the next question is whether we need to do rebiopsy or not, or is it too early to do the rebiopsy?
Okay, I have a question too. So where at this point in this time course of the patient's illness was the biopsy? Because we were told that she was unable to lie prone. So which month was it that she was biopsied?
The biopsy was did at May.
Oh, May.
This time.
I see. And that's already when the proteinuria has started to come back.
Yes.
Because initially it looks like she's responding, and so that it's at May. All right.
So anyone have other differential diagnosis besides of lupus relapse? Or not lupus relapse, it's lupus nephritis. Because they use the immunosuppressive for treatment of transverse myelitis, not lupus nephritis. So besides lupus nephritis, do you have anyone have any idea besides lupus nephritis to be a cause of increased proteinuria in this case?
I'm Kriang Tang Sanga. Let me start that instead of looking at the A or B, I think about the mechanism of proteinuria. If it is significant, it could be glomerular, tubular, or overflow proteinuria. And glomerular disease could be intrinsic or extrinsic. I mean that intrinsic means the primary glomerular disease. And then we have to look into any possibilities. If there is a transverse myelitis and dysfunction of the bladder, not sure about recurrent obstructive uropathy can cause any significant glomerular disease, like a glomerular sclerosis or so forth. The other is about the secondary cause. SLE is one of the possibility in which we have to look in the first or second priority. Anything else should be vasculitis. It depends very much on the clinical and laboratory support and that evidence. Otherwise, we have to look into another like deep vein thrombosis, whether any possibility of deep vein thrombosis as a cause of the increased glomerular pressure and cause the proteinuria. And the other is something like intrinsic kidney disease, as you mentioned before, whatsoever, that depends on the pathological findings. The other is overflow proteinuria, even though this is unlikely, but just keep in mind about overflow proteinuria as well, and also tubular. Any possibility of tubular or not depends on the history and data to support that. Thank you.
Marissa, do you respond to Dr. Kriang for his opinion?
Yeah, I think that could be possible because patient had transverse myelitis and also urinary retention. So the overflow proteinuria and or myelitis related vasculitis could be possible causes of proteinuria, because we see in the disease activity here there are decreasing of the double-stranded DNA and also increasing of C3C4. So that means that the disease activity of the SLE itself is improving, but the proteinuria not linear with the result of the serological data. So I think we should keep in mind that maybe there are any other cause that could be glomerular involvement in this patient rather than SLE itself.
So you recheck the urine and no pyuria, and you do ultrasound and no obstruction, and you check renal vein, and the renal vein is patent, right?
Yes.
Okay.
No, there is no pyuria and also no obstruction because patients was with the urinary catheter every day, so the urine, the flow of the urine is good.
So would it be possible to be intrinsic as physician nephritis or other non-glomerular disease? So if it not, so we can proceed to kidney biopsy if no contraindication, and the patient can lie down in prone position.
So this is the result of kidney biopsy. Maybe I want help from the pathologist. Maybe Dr. Monique, can you help?
Maybe let the fellow to read first, and when and pathologist will respond to them.
PDS-nya ya, PLPA, PDS, PDS-PA. Ada.
Any fellow from Singapore, Hong Kong, or Philippines, or any place want to read the kidney pathology?
Ada sih.
So, any volunteer? No. Any fellow, second year fellow? I think it's simple. They have a marker and pointer. It's not too difficult because they already marked. Anyone want to review the pathology?
So I'm Dr. Natasit from King Chulalongkorn Memorial Hospital, the second year fellow. So I will would like to start with the first figure of the renal pathologist first. Can we start with the first figure?
Go back, please.
Picture belakang. Terus picture. First picture. Ya, first picture yang ini. Patologi.
So at first, this patient is a female, 19 years old, and present with persistent proteinuria after the third relapse of suspected from lupus nephritis and history of transverse myelitis after the intravenous cyclophosphamide for the NIH regimen induction, and still develop the proteinuria after the induction for 6 months, and the proteinuria is worsening. And despite of the normal complementemia and anti-double strand DNA is decreased, so I think the active disease of lupus nephritis need to be think of, but it need to see it need to figure out the cause of the worsening proteinuria in this patient. So let's start with the first figure. Yeah. So this is the H&E staining, and if the patients suffer from the proteinuria, we need to look at the GBM first. The GBM in this figure, I think, is maybe not thickening enough. So we need to take a look in other staining. But this H&E, other H&E details is, I think it had a mesangial hypercellularity. Yeah. In the second picture, in this picture, I think the mesangial we still see the mesangial hypercellularity, and maybe I think it may have the mesangial expansion, and the GBM also not thickening, I think. And other structure nearby, I think we will see the maybe the interstitial infiltration by the mononuclear cell at the upper corner of the figure. Yeah, so let's take a look at the next picture. So I think this is also the H&E staining, and the the detail of the mesangial hypercellularity is, I think, is maybe we agree that it is still seen in this picture, and the GBM, I think, is not beginning, still not beginning. Yeah. So and other nearby structures, I think, if maybe we see the interstitial infiltration with mononuclear cell again. Yeah, let's go to the next picture, please. And this is the PAS staining. We will see that at first we look at the mesangial hypercellularity, that it still see the mesangial hypercellularity, and the GBM in this picture. I'm not sure, but I think it's a bit thickening, but we need to look more in the next picture or other picture. And this picture, we will see the at left side, we will see the vascular flow, I think, and the upper corner at 11 o'clock, I think, is had the mesangial expansion. Yeah. And at the GBM, I think I'm not sure that is thickening enough. So maybe I will take a look at the other picture first. So and we still see the interstitial inflammation at the 11 to 12 o'clock at the nearby structure of the interstitial. Yeah. So please go to the next picture. So this is the Mason trichome staining. At the central, about the 9 o'clock to 11 o'clock, we will see that I'm not sure it is a nodular sclerosis with the mesangial hypercellularity. I'm not sure. And the other details still, we still see the interstitial inflammation, the mononuclear infiltrate in the left side, in the 9 o'clock to 11 o'clock. So
interrupt you. Do you see the feature of lupus nephritis? Like wine loop or hairline combine or
yeah, the side of the nephritis or active lupus in the picture that we see, that the first to this page, to this picture, I think we still not see the crescentic, or we still not see the wide loop, I think, or endocapillary hypercellularity. I still not seen, but I'm not sure. Yeah. So still no evidence of the active lupus nephritis from the first to this picture.
in this picture, do you think it is a simple sclerosis, or do you think it's a composed of the glomerular capillary, or just simple sclerosis?
I think it may be from the focal sclerosis.
And if you're not sure, you can confirm by the other picture.
I'm not sure, but I need more understanding to reevaluate this glomerulus. Yeah. So this is a Mason trichome staining again, and we still not see the crescentic or the endocapillary hypercellularity or wide loop, and the mesangial hypercellularity. I think is we still see the mesangial hypercellularity at the maybe 8 o'clock and 12, 11 to
If similar, you can skip
Yeah,
to the
okay.
next slide.
We will take a look at next picture. Yeah. So this
So how
is
about this
the
one? Is it thrombus or segmental sclerosis? By
this
silver
is
staining.
the silver staining. We will see that we see that at about 9 to 11 o'clock, we will see the inhomogeneous staining pattern. I think is maybe from, I'm not sure, maybe from fibrinoid necrosis or not. I'm not sure. Yeah.
The capillary lumen is gone, matrix expansion, and a cellular matrix. What do you think? Is it vessel or is it simple sclerosis or is it thrombosis?
I think if maybe from the nodular sclerosis. Yes.
Okay. Segment sclerosis. And do you see spike from silver staining, spike and hole? Because you are differential of lupus, maybe class 5.
And this picture, I think I cannot see the spike and hole pattern.
Are you sure?
I'm not sure, but
Okay, maybe next slide. Maybe next slide.
Next slide. And this picture, the Mason trichome.
This is silver staining.
Oh, silver stain, sorry. Can we zoom at the GBM or the
You may write it's silver on top of the trichome staining. Okay. Okay, if you don't see, the next slide.
I can still not see the spike and hole. Yeah.
But you see inflammation around the Bowman capsule, right?
Yes.
Okay. Next slide, please, because we have 12 minutes left.
So this is the
How about the vessel? Is it okay for you?
I think it's okay.
Okay.
We still not see the arterial hyalinosis on medial thickening of the vessel wall. And
how about this tubule?
the tubule is the structure of tubule is, I think it is maybe from the atrophy and disturb disalignment of the tubular structure. And we still see the mononuclear infiltration. Yeah.
So how many slides left? Orisa, how many slides left?
About 10 slides.
10 left. Okay, let's move fast. Okay. Let's move faster. Next slide.
Oh, this slide is obviously we see that we have the inhomogeneous and GBM thickening and the staining of the silver staining. Yeah, I think
what do you see? What do you see? Spike or hole? Or both?
Both.
Okay.
Yeah.
Marker. Okay. Thank you. Okay, next slide, please. Okay. Next, please. How about this one?
This is the mesothelioma of the vessel. We still not seeing the
Okay.
no, not seeing the arterial hyalinosis or thickening.
Next slide, please.
Yeah.
Next.
This picture too.
This is a bifurcation. Okay, next slide. And how about this one?
I think at the central of the picture, we see the inhomogeneous staining of the H&E in intraluminal of the tubula. Maybe
Okay. You can say it's
it's
past.
higher in class. Yeah.
Yes. Okay, next slide.
This
Next
structure.
slide.
Yeah.
Next slide.
Yeah.
Next slide. Okay, how about this one?
I think overall of the tubula and interstitium is maybe we will see that we decided infiltration of the white blood cell, and that the previous slide showed that this is a mononuclear cell with the and
How many percentage of TI inflammation and fibrosis?
I think in this picture, in my opinion, I think it's about 15 or 20%.
Do you see it tubulitis or margination of leukocyte in tubular capillary, something like that?
The tubulitis, I think in the previous slide, we will see the tubular trophy, but the tubulitis, I think is
Maybe this is the last
not
slide.
sure.
So finally, what did you conclude?
In the conclusion, so we'll see one glomeruli have the nodular sclerosis, and we will see the spike and hole of the most of the glomerular structure, and we see the interstitial
You think it's
inflammation.
the lupus class what? Which? Class 5? 5 plus?
Yeah. I
Part,
think it's
part
class
2,
5.
part 3? Part 2 or part 3?
Not, we will not, I have not seen the
3A or 3C, S, and you need to scoring.
I think it's 5, not plus.
Not plus. Okay, 5. And how about activity index? Activity and chronicity index.
0.
0 activity and chronicity.
Coincidence.
Okay. Maybe we move to IF or this one, the tubulitis. Okay. This is AGA. T3, 2 plus. T1Q, 2 plus. I just read it. IgG, 3 plus. Oh, is it confirmed your diagnosis or not? If yes, so maybe we will allow kidney pathologists to review the answer for us.
Okay, hello, greetings from the anatomical pathology department. My name is Monique, and yeah, this is the case which received by us in the May. We received 2 core biopsies, and we've done H&E, histopathology, and also immunofluorescence. We don't have electron microscopy right now, so we cannot confirm that. So in this histopathological specimen, we count about 17 glomeruli, and there is 1 sclerosis segmental Can you take the pictures that beautifully described by earlier as an sclerosis? This one, yes. First, when I look at this, yes, I think also, is it thrombi or is it sclerosis? But as we look at the deeper level and the trichrome and the silver, I conclude that it's more likely a sclerosis. So this is the chronic sign, and then in the all of the lumen capillaries are patterned, and we see some impression of the mesangial expansion and also the impression of the subepithelial deposit, but it's so subtle, so we have to check on the 1000 times magnification to see that the subepithelial deposits. Yes, this is with the immersion oil, we see there is some subtle subepithelial deposit in there and some sort of spike there. So we think more likely this is a membranous pattern. And then, yes, all of the description is already stated before. We don't have the impression of the endocapillary proliferation, and also we don't see any crescents. And we also see in the compartment of the tubuli, we see a mild atrophy. And then the interstitial, we also notice some inflammatory cells. So yes, there is no arterial thickening, I agree. And then there is some cast later on, the protein casts in tubules. This is the inflammatory cells in the interstitium. So when I diagnosed this case, there is some scoring of the interstitial inflammation of the mild one. In the EF, yes, the EF, we receive 4 glomeruli, and this is a full house pattern. So if we conclude the histopathological findings and the EF, this is more likely the lupus nephritis in the membranous pattern, the class 5. There is also the mesangial proliferation, probably combination within class 2. And the index activity, I scored interstitial inflammation in 1 and neutrophils. Others are 0. And we notice the sclerosis segmental. So this is 1, and mild tubular atrophy and mild infrabasal social. So it's 3. So yeah, it's as far as we can conclude this one. So we don't have any EM, so we cannot evaluate others, tubular reticular inclusion or others. Okay, so maybe that's all from me. Thank you for the opportunity.
Thank you so much. Dr. Orisa, do you have any question or you review for maybe 1 or 2 slides, review the case?
Yeah, so the patient probably is SLE with transverse myelitis, with mucocutaneous musculoskeletal and also kidney involvement, lupus nephritis class 5, and also positive antiphospholipid with lupus anticoagulant weak positive. The treatment right now is metylprednisolone 4 milligrams, hydroxychloroquine 200 milligrams, calcium carbonate 3 times 1200, vitamin D3 1000 unit, lisinopril 110 milligrams, cotrimoxazole 960 milligrams, and myfortic 2 times 720 milligrams since May 24. So maybe this is the question: is what is the best treatment for our patient?
So, any volunteer to answer what is the appropriate treatment for lupus class 5 while the patient have got NIH regimen for I go for my six courses and also my MMF since May 2024. How many slides left? All Lisa?
Yeah, that's it. That's it. Prof.
Okay. Maybe next time we're gonna have poll to patient to vote. Okay, because the times is limited. Dr. Pringle, do you have any final call for us? Right. Or any comment or thought? Do you want to say anything? If not, maybe I gonna Dr. Sunita, do you want to close the session? We're gonna skip next month for ISPD 2024, and we will begin the case discussion in October. Probably it's 29 for PD case discussion. Dr. Sunita,
Sorry, I can't make any announcements. We have an overhead, very loud announcement going on, but I will leave it to you, Golf. And I want to thank the team over at Indonesia for the very nice presentation, especially the very nice slides that were shared.
yeah, thank you. Thank you for Orisa to present the case. It's very nice and wonderful, and also pathologist who review the answer for us. Thank you everyone to join this session, and hope to see you again in October 29. Thank you. And I think maybe Philippines or gonna volunteer for the PD case discussion next time.